Welcome to Module 1 in the Risk Communication and Community Engagement series. Module 1 is an overview of risk communication and community engagement.
It is divided into two parts. The first part introduces the foundations of risk communication and risk perception. The second part then focuses on managing uncertainty, establishing trust, and engagement.
My name is Marcia Vanderford, and I have long experience in risk communication both at the United States CDC and at WHO. I will be guiding you through this session. We will start with the foundations of risk communication and community engagement. The SARS outbreak that went from 2002 to 2004 was the first severe global outbreak of the 21st century. It was in many ways a turning point in global health. It laid bare the impact that outbreaks can have in a highly connected world, and it created a new global field of practice for risk communication and community engagement. Before this, risk communication was created and applied primarily in the United States in the midst of mounting public concerns about environmental risks to human health. The book on this slide, Understanding Risk, was a foundational resource for communicating about environmental health hazards. But following SARS, risk communication was broadly applied to health emergencies, and it became a requirement under the International Health Regulations in 2005. The first WHO authored guideline was called Outbreak Communication that focused on risk communication and was authored as the foundation of global health risk communication. Since SARS, outbreak communication or risk communication has been followed and expanded at WHO through its regional offices and other national agencies, and has been prompted by evidence-based and best practice documents, a few of which appear here, and they apply both to all hazards and some to specific diseases such as pandemic influenza. In the decade that followed, over 1,000 field studies, case studies, and message analyses have directly addressed public health interventions that we now refer to as risk communication and community engagement. And WHO's practice of risk communication and community engagement is built upon this body of work. So, what is risk communication and community engagement? Well, there are many definitions, but the one derived from the IHR Working Group on Risk Communication in 2009 focuses on risk communication and community engagement as two-way communication or dialogue in real time between health experts and at-risk groups about a given risk. The goal is to encourage informed decision-making by those who are at risk for disease or other harms. In the past, some have suggested that risk communication is primarily done through mass media, and others suggested that it was most directly related to community engagement. But today, we recognize that effective communication of risk uses an integrated model and uses the full range of communication channels and strategies and areas of expertise to achieve our objective. Any channel or function or platform and context that contributes to informed decision making to help people make good decisions to protect themselves and those they love from a health threat can be considered part of risk communication and community engagement. So, how is communicating risks during an outbreak or other health crisis different from communicating during peacetime when there is not an outbreak or a crisis? WHO's outbreak communication explains it in this way. When risk communication and community engagement occur in an emergency context, the crisis produces unique challenges in the political, economic, cultural context in which the outbreak occurs. Consider the public health context of the crisis shown in the top row of blocks. Outbreaks are urgent emergencies, and they are accompanied by rapid efforts to care for cases, to prevent spread, and to bring the outbreak under control. Decisions, often with life saving potential, have to be made rapidly, and actions need to follow rapidly, often with support from an informed public. Ideally, decisions should be based on solid scientific information, but often much is unknown about the disease and who is at risk because of the unpredictable and emerging nature of public health emergencies. In this context, setbacks and surprises are a common feature of the outbreak response, including sudden surges in cases, spread to another country after what was thought to be its peak, discovery of rapid mutations or changes in a disease, new risk groups that emerge, new modes of transmission or change, and treatments that might fail if drug resistance develops. These surprises can emerge rapidly. Then add this to the crisis for public health agencies. That is what is also occurring in the public context. And so, looking at the bottom row of boxes, outbreaks can be for the public alarming events and elicit great anxiety, while attendant high demand for information occurs among the public at the time when much is still uncertain for public health agencies. Uncertainty and concern can lead the public to extreme behaviors. For example, stigmatization of patients or minority groups. And we saw this during both outbreaks of coronavirus, now for COVID-19, and during SARS between 2002 and 2004. And sometimes we see a loss of confidence in the government. Public reaction like these can give outbreaks another shared feature: high political visibility. Public anxiety, social disruption, and potential economic losses often accompany an outbreak. And if it does, it grabs and requires the attention of government levels far higher than ministries of health. There's almost always, a behavioral component to controlling disease, preventing person to person transmission, or controlling human exposure to animal reservoirs or other environmental sources of injury or harm. So, whether the public adheres to healthy behaviors or unproductive ones in the midst of a crisis can greatly impact the ability of health agencies to control it. For example, public information about the importance of daily temperature checks and early reporting of fever and isolation of cases proved decisive in bringing China's 2002 SARS outbreak to an end. So the combination of these shared and common features create a complex challenge for risk communication. How then does risk communication and community engagement, how then can they be used in an outbreak to shape these interactive forces in ways that favor rapid containment while also mitigating social and economic consequences? We address these challenges with a focus on the core elements of risk communication and community engagement. That is, influencing risk perception, managing uncertainty, building trust, and engagement. Let's consider first the key risk communication and community engagement concept of risk perception, how it relates to one of our challenges: motivating productive, protective health behaviors during an outbreak or other event. Consider which of these you think are a part of risk perception. Assessment by health and medical experts about the severity and prevalence of a threat to health or safety, public opinion about the likelihood that harm will occur to an individual's health or the health of someone they care about, individual assessment about the possibility of harm to one's livelihood or the local economy, politicians' judgments about the potential for a threat to harm their reputation, or health authorities' judgment about the potential for a crisis to damage its credibility amongst the people it serves. Of course, the right answer is all of the above. Risk communication is judgment about the likelihood of harm that can be health or reputation or the economy or property or livelihood. Public judgment about these risks are likely to be different than those of experts. We can see the importance of influencing risk communication, for example, during COVID-19, where we are seeing people's risk perception at different levels. The target in the middle of the diagram represents individual risk perception that is sufficient to prompt individuals to adopt relevant, recommended protective behaviors to reduce a health threat that is appropriate to their risk level. And that's our goal. On the left side of the diagram are people who might be characterized as overly cautious. They perceive the risk to be so great that they are not only implementing public health recommendations, but are also failing to take low-risk activities that they need to take to stay healthy. For example, they might avoid going to a clinic or a hospital for non-COVID medical services. Parents might not be taking their children for routine immunizations. On the right hand of the diagram are groups who react differently to perceptions of high risk. These groups feel so overwhelmed by the threat that they may have become fatalistic. Behavioral economist Nuit Nobel calls this learned helplessness. These groups perceive the risk as so grim, they think nothing I do will matter anyway. And individuals in this group experience a high level of risk perception from COVID-19, but a low level of confidence in solutions offered by health authorities, and also a low level of confidence in their own ability to do and sustain health recommendations until a vaccine or other treatments are available. Behavioral scientists advise us that our messages about risk are more effective when people feel confident about their ability to solve a problem. So moving the fatalistic means being oriented to solutions and actions they can take. Our risk messages for COVID-19 need to focus on this. According to the July survey conducted in almost 70 countries by Johns Hopkins University, they found that people's level of confidence in their ability to protect themselves was low. Only about 50% felt confidence and were less likely to protect and practice prevention measures for COVID-19. So, if health communication people share information that creates a perception of high risk level, that is, if risk communication messages create a perception of high risk, but they don't convince people that recommended health behaviors work or that the people are capable of enacting and sustaining these behaviors, people may just give up trying. Finally, on the lower right-hand side of the diagram are people we might label unconcerned. People who fall into this group perceive only a low level of risk or none at all. The underconcerned may be experiencing optimism bias, that is, the belief that bad things are less likely to fall to oneself than to others. Optimism bias is attractive because it helps people to avoid fear and negative feelings, but it can also lead them to underestimate their likelihood of harm. In the case of COVID-19, it makes them underestimate their own risk of contracting COVID or passing it on to others. They ignore public health warnings. Optimism bias is also applicable in our response to COVID-19, as Dahlberg and Johns Hopkins studies identified COVID-19 optimism bias as a risk perception challenge for this disease, as it was found to be common amongst people in their global surveys. We know that across this spectrum, risk communication must combine hope and worry in messages to prompt healthy behavior in these at-risk groups. How can we help people to understand their level of risk and how to respond in healthy ways? Unfortunately, influencing the public's perception of risk is not as simple as explaining the science. As you can see here, risk perception has two dimensions: the cognitive dimension on the right, which relates to how much people know about and understand risks, and the emotional dimension on the left, which relates to how we feel about the risks. Science and medical experts tend to understand risks through the cognitive dimension. Their risk assessments ask, how severe are the outcomes of the threat, and how prevalent is the threat and its related harms? But while experts define risks in this technical way, the public has a richer, more complex view that incorporates value-laden considerations such as equity, catastrophic potential, and controllability. You can see some of the values identified with public judgments about risk on the left side of this scale. We know that simply addressing the cognitive dimension of the threat will not convince at-risk groups to take on recommended behaviors. Risk communication must address both values and cognitive aspects. The science must be explained, but combined with an understanding that for many laypersons, some characteristics of the threat are more worrisome than others. We are more likely to be worried by threats that have catastrophic outcomes, are out of our control, have permanent outcomes that affect the next generation, that we did not choose to be exposed to, and those that are new. These and other characteristics are important parts of our analyses and our messaging. What are some key implications of the concept of risk perception for messaging to influence behaviors? Well, for the underconcerned, the key to overcoming pervasive optimism bias is to make COVID-19 salient. For example, Halpern and his co-authors advocate that including fewer statistics, but instead focusing on individual people as victims of COVID-19 is important. This approach increases the likelihood that people will see the risk to people like themselves rather than to faceless numbers. Halpern calls this the identifiable victim effect and believes that in the United States, this was the cause of public support to purchase ventilators for people dying in hospitals, in comparison with less public support for testing and contact tracing, measures which would have saved many more lives in the United States statistically, but were harder for people to visualize and identify with. Another messaging approach is to localize the threat, bringing the impact of disease close by. This can make risks more salient, as people tend to feel less threatened by harms that are farther away and more threatened by harms that are close at hand. Then, for people who are not taking action because they feel fatalistic, it is important to build confidence in our messages in agencies that are responding to the threat, and to build self-efficacy in people who need to enact and sustain healthy behaviors. In short, the key to influencing risk perception is to balance worry and hope.
This concludes Module 1A. We hope that you will now continue on to Module 1B on managing uncertainty, establishing trust, and engagement.